Okay, so very warm welcome to everyone. Thank you for taking your time out in the evening. I know how incredibly busy everyone is at the moment, and thank you for all the contributors that have come to speak today as well. So we've got a really busy agenda, and it's the usual stuff. So if you have a question, please put it in the chat, or please raise your hand as well. And yeah, and please mute yourself otherwise. So if we just get going then, so we've got Claire, who's going to give us a little bit of update on the home monitoring service first. So Claire, if I could just, yeah.
Great, thanks, Rita. So I've been allocated 10 minutes and I've got 6 slides, so hopefully I'll finish sooner than 10 minutes. So just to say that we've been providing a home monitoring service in Newham since the beginning of the previous COVID surge in the second week of April. And since then, we've had 1,200 patients come through the service, and our current caseload is about 140, which is probably the highest caseload we've had, actually. So over the summer, we reviewed our service, and I know nationally they were reviewing the services and looking at outcomes across the board with COVID. And I think following those reviews, they identified that patients over 65 and those under 65 with certain risk criteria had worse outcomes. And as a result of that, NHS England very late in the day has sort of waded into the piece and started dictating terms for monitoring and trying to improve the services and the criteria. So we've had to broaden our case mix, and I think practices themselves, Kavita was just saying at the beginning how she's reviewing her COVID diagnoses and the patients who should be put into home monitoring. I don't think all these patients were previously, and so if this leads to better outcomes, then that's only got to be a positive thing. So I know that practices now are reviewing their lists. They've got their shielding lists, their clinically extremely vulnerable lists, and hopefully all of these patients, they will either be monitoring themselves or they will be referring into our service. So if we can have the next slide. So in North East London, they are reviewing the oximetry plans across the 7 boroughs, and they're trying to standardise them. I think Tower Hamlets and Newham were 2 boroughs that had very robust services from the beginning, and I think they've pretty well met all these criteria. We've been taking referrals from the emergency departments, UTCs, but we haven't been having them from LES and 111, so that's a new thing for us in Newham. And we have had a 7-day service from 8 till 8. We've got clinical assessment when they're onboarded, and they have care plans, so they're either put into text monitoring or telephone monitoring. The patients have clear instructions and deterioration and escalation criteria. We have had specialist support. We found the Newham ambulatory care consultants have been extremely supportive. And then recently the new thing is that we're having to do daily and weekly reporting to NHS England. I'm saying we, it's a bit of a royal we, because I actually have been quite peripheral in this service. The team we had in London Health and Carpenters Practice set this up. I did try to advise them on how to do it, but invariably my advice was incorrect and they just set the whole thing up themselves. And I know some of them are on the call today, so just a repeated thank you for all the work they've done, both in the last surge and more recently during December when it was extremely busy. So if you have the next slide. So the other action they want us to do is to start developing COVID virtual wards, and this is to enable early discharge from hospitals. So we've always taken referrals from GP practices, then we were taking referrals from the emergency departments in May, June time, and then since then through the autumn. And then recently there has been a big push, and I know some of our secondary care colleagues are on the call, to try and decant patients from the hospital to release beds for those needing oxygen, and so they've developed a virtual ward in the community. We aren't involved in this service, so we are discharging these patients through the integrated discharge hub to the telehealth service, which is an ELFT service, and it's based at East Ham Care Centre. There was just a webinar, a London webinar today about COVID virtual wards. There is slight confusion, so this is a very new thing. The guidance has only come out in the last couple of weeks. People are mobilising the services quite quickly. It's being done differently across London. So I think it's very much for us to determine how best we can provide that in Newham. And I think across North East London, they probably will set criteria. Because we're part of Bart's Trust, I'm sure the 3 well boroughs will use very, very similar pathways and staff mixes. And then the third action was about the data and getting the digital architecture. So we set up EMIS templates in our EMIS practice to support the service, and we had standard codes, but they now have developed London-wide codes using SNOMED. And so I know that Osman Bhatti and CEG are developing a new template. Our service have given feedback today because we don't think it's as good as the one that we're currently using, but we do want to have the codes that everybody's using, because then they could be standard searches. So at the beginning of the service, we were doing manual reporting, which is quite time consuming. I know Jenny Mazzarella's on the call, and they were the commissioners who supported us with developing this program. So we're hoping that as the digital architecture improves, it will be much, much easier to do the reporting. They also are trying to standardize some of the support and the texting services. So I think there's going to be a lot of change, and I do think this is being found to be so beneficial that it's going to create or support a step change in remote monitoring for all long-term conditions across the piece. And I think this is why NHS England actually is getting very, very engaged in the last few months, because they can see that this could be a really positive outcome from the COVID epidemic. Next slide. I think everybody, or many people on this call, I know Rima Vade is on the call, and I know that she was often passing us messages, because in December, when we had the most recent surge, our service was really hammered. I mean, I don't think any of us anticipated in the first week of December quite how bad things were going to get. And our staff were having to do overtime to quite high levels, and we were desperately trying to recruit additional staff to increase the capacity. And it simply wasn't sustainable, and they did extremely well. But fortunately, we have now managed to expand the workforce by about ×3, and I'm hoping that people will see that the service has improved. I know for a couple of weeks practices were having real difficulty because all of our slots were full, but I think we are monitoring, and every day we can see that there is spare capacity. So if anybody finds there's any problems with accessing appointments, please do let us know, because you should be able to get the service appointments available every day now. But we also thought that it would be really helpful for some practices if they could take on the lower risk cases. So patients who have got PO2s above 95%, we said that we could provide delivery and collection and decontamination of the monitors if they then could just do the daily texting to the patients to keep an eye on them, and we'd also provide the leaflets, etc., etc. So if you want to go to the next slide. Oh, sorry. So these are slides just showing the activity. So this is some data. So you can see the graph on the left shows the peak in May, and then we had the quiet months of the summer, and then the enormous escalation over the autumn. So the blue line is the total monthly caseload, and the red line is the monthly referrals. The middle graph is the weekly changes. So you can see there was a bit of a dip, and then December it went stratospheric. And then the graph on the right just shows the source of the referrals. So with the green line is the hot hub that we used to have in the Vicarage Lane site. We closed that in December in order to convert the capacity over to the home monitoring service, because most of the patients ended up being in the home monitoring service. The red line are the referrals from ED, and the blue line is the referrals from general practice. So that was when the service was under extreme pressure. Sorry, you can have the next slide after that. Yeah, so this is just showing the home monitoring versus the self-monitoring. So home monitoring is cross-organisational booking via EMIS, delivery, collection, decontamination of the kit, information leaflets, deterioration, escalation, signs and instructions, patient assessment management plan for text monitoring or self-monitoring, or daily service monitoring. So this is done by the team, and the patients first come on board. And then there's the discharge assessment and oximeter collection, and then we're now doing the data collection. So with the self-monitoring, so there are 2 clinics you can choose from on EMIS. If you're prepared to do the monitoring yourself by text, we'll do the delivery and the collection. And then the last line at the bottom of the slide is just saying if practices like Kavita's are doing their own patient monitoring if they could give us the data so we can give NHS England a comprehensive report about all of the patients, the numbers of patients being monitored by primary care. So things are changing at pace, and so people will see that the CEG home monitoring templates will be changing quite soon. People also be starting to see virtual ward patients. So we'll have patients who are being discharged early from the secondary care admissions. They'll be discharged into a virtual ward, which will be an intermediate service, which is a sort of integrated care service, hopefully with the acute consultant supporting as well, but without telehealth. And then I think the GP Federation will be providing some GP backup as well. And like I say, I think this is the beginning of a very, very exciting time in healthcare, actually, where we will get much more home monitoring and supported care for patients, which will make life a lot easier for them, and hopefully it will improve standards, and it'll be really great to be working in as clinicians. So I don't know if you want to have questions now or at the end, Kavita.
We could do a couple of minutes of questions. So and then we'll take like a look. Has anybody got any specific questions for Claire at all? Is anybody else doing any? Is anybody else? I mean, I think for me, it's really about encouraging practices to take on the home monitoring themselves, because it is quite simple, Claire, and to take that pressure off the home monitoring service if we can as well. So, I mean, I can give is there anybody else on the call that's doing their own home monitoring service? If you just want to put your hand up or shout out, otherwise you're going to have to hear my voice. I can't see any hands up.
A couple of hands.
Oh, Rajesh, you've got your hand up. Yep, and Jackie's got her hand up as well. Yeah, go on, Rajesh.
So just one question for Claire. What I find is sometimes when I'm doing extended hours through the hub or taking one-on-one calls coming down, obviously we see a lot of these kind of patients who have COVID symptoms. We haven't got that cross-organizational referral into any of these services. Is there any way we can look into that?
Yeah, no, definitely. And I think the out of hours has been an issue. So we've got a really good relationship with ED. So we could easily set up something similarly with the out of hours service. And I know that across North East London, Kate Adams will be working on getting links with the 111 service as well.
Thank you.
Thanks, Claire. And Jackie?
So just tapping into what Claire's saying, actually, from both a 111 perspective and also from our crews on scene. So we're currently able to, from 111, book into these services, which is really helpful. And we're just currently working through a method to allow crews who identify these patients to speak to a doctor within the 111 service, and obviously tie that up as well. So just that there's a very whole system approach to this piece of work, and there's a lot of work going into to get the benefit from the work that's being done by primary care.
So can I clarify, Jackie? So 111 can book into the home monitoring service directly, Claire, is that correct? I mean, I'm sure you are right, Jackie. I was just like, I didn't know that. Yeah.
So people outside the service need to send an email. So that's something that
I didn't know that. Okay.
At the moment, yeah.
All right, then that explains the huge pressures that you've been on you as well. And just to say, I don't know if anyone else, but you know, it is really quite simple to do in practice, just to have that confidence to do it. I mean, it's not. I'm sure it's not the simplicity that's the issue; it's the capacity issues in primary care as well. But it is once you get used to it. And we're actually just calling patients daily rather than doing the flurry texting, but I'm sure that makes it even simpler as well. So I'm just going to move on and to move on to Andrew. Thank you, Andrew.
Hi, thank you very much. Nice to see you all, those that I can see. So my brief is to give an update on the hospital. I've been given 5 minutes. I'll probably take all the 5 minutes, but happy to take any questions either as we go along or at the end. I mean, just to put this in context, it would be wrong to tell you anything at the moment other than the hospital remains under extreme strain. I think we're coping incredibly well with it, and that strain has levelled off, but we are in no way operating in a normal model, and I think you're all aware of that. We currently have no paediatric inpatients. They're all at the Royal London Hospital, and we're using our children's ward, which was refurbished by Bart's Charity at great expense a couple of years ago, is full of adults with COVID. Our intensive care ward has expanded to Phil Manor Park ward, which so it's gone up. It's increased by 3 or 4 beds in that space, and is also using the entirety of a theatre recovery suite. Elective operating in this hospital has stopped. We're doing a tiny amount in the independent sector, but really very little at all. Nursing staffing is either at or below minimum ratios on both general and critical care wards, in an attempt to look after all the patients that we've got to, and in light of the shortages of nursing staff there are across the whole sector. There's been significant redeployment of doctors and nurses, both within Newham, so anaesthetists working in intensive care, junior doctors from obs and gynae, from paediatrics, from surgery working in medicine and in intensive care, but also redeployment of doctors across the Royal London Hospital working as nurses. So we currently have 9 junior doctors from Newham Hospital who are working on a 3-on, 3-off rota at the Royal London Hospital as HCAs, because the sector is that short of nurses. And that gives you a clue of the strain that the system is still under. Visiting to the hospital has all but stopped. We've never really restarted that since March at any scale, but the hospital is a very quiet place. And then recently, with the opening of the Nightingale Hospital, which is run by Nelft, we've started to get some of their acute deteriorating patients as well. And of the 35 patients admitted to the Nightingale so far, at least 4 of them have had an acute deterioration and been admitted to Newham Hospital emergency department for ongoing care, 2 of them with COVID. So this is a really, really abnormal geography we're working under. The London Ambulance Divert for children remains on, so children are taken directly to Royal London Hospital by LAS. But the COVID divert we had in place for several weeks has now stopped, and all patients with COVID are coming to Newham Hospital if they're picked up in the Newham area. Some general statistics about the hospital. So we currently have 169 COVID cases in the hospital. At our maximum, we were at 184, so that has decreased a little bit, and I think we can feel that. Our intensive care unit has 12 ventilated patients and 7 non-ventilated patients. That's a total of 19 patients, and at our maximum, we were up at 22, so again, that is a slight easing off, but there's been no real reduction over the past 7 to 10 days, and that number has been static over that time. And it's going to be several weeks until we see a reduction in intensive care capacity because of the length of stay and because of the sickness of the patients. We currently have 7 patients in our wards on CPAP and 10 patients with Optiflow. These are patients that are normally sick enough to be treated in intensive care. Because of lack of capacity in intensive care, they are being looked after in a general medical ward, and normally with 1 trained CPAP nurse for 4 or 5 patients, with a bit of help from untrained nurses, but nevertheless, again, a really diluted nursing ratio there. So that's 17 patients on some form of NIV, and at our worst, we were up at 50. It's not all negative, though. There are some positive things. So we have been running our vaccine programme now in this hospital. I lose track. It's either 3 weeks or 4 weeks. We've now vaccinated 1,000 members of our staff, and contractors included. We've probably got about 2,200. So we're still at less than 50%, but nevertheless, a good number to have reached. We've also been actively vaccinating frontline staff from the community, including health and social care workers, undertakers, unofficial carers and volunteers, trying to vaccinate anybody that's in some sort of caring role or frontline role, to make the best use of the vaccine that we have. We have not yet been in the difficult position of having to throw away any vaccine, which I'm sure is encouraging for all of you. We've been responsible and used all the vaccine we've got. And to date, we've exclusively used the Pfizer vaccine. Helen's going to talk about the emergency department, so I'm not going to go into that. But it does feel just not quite as bad as it has done. At one stage, we had ambulance delays of hours and hours and hours. We had paramedics, working 3, 4, 5, 6 hours over the shift end, waiting outside an ambulance with patients. We had queues of ambulances of up to 10 at times. That has largely eased off, and ED feels like an easier place, but it's still very difficult. We've run a hot and a cold emergency department for all of this year since March, with all the difficulties that will present as well. So everything is duplicated. But ED is feeling a bit better. We're working much more closely with our colleagues. I mean, I've always been really careful to try and work closely with you and with all of our community and primary care colleagues. But actually, the work that Claire Davison and her colleagues have been doing in the hospital has really brought that connection between primary care, community care, and secondary care much closer. And that's a valuable link that I think is going to continue to be exploited in the future and made the most of in the future. I think we've all been really buoyed up by the improvement in the community infection rates, and the fact they've come down to 600 odd per 100,000 this week is a massive step forward for us. And despite the fact we're not necessarily feeling that in the hospital, knowing there's less of it in the community is a big deal for us. We set up a patient contact centre, so we're able to allow relatives of patients to get information about their patients. And that was a big thing that was lacking in the first surge, and it's been a massive improvement for us this time. We've got medical examiners on board who have reviewed every death in December and are now working through our deaths in January. As you imagine, there's a lot of those deaths. But those medical examiners are making sure that any shortfallings in care are picked up at an early stage so we can review them properly, but also make sure that death certification is accurate and as helpful as possible for families and also for the coroner. And then finally, some real superstars have been identified in the hospital over this year. You will have seen on BBC London on Friday some amazing staff from the intensive care unit, including James Napier, who's our CD for ICU, Elizabeth Abraham, who's our Abram, and Carlos da Costa, who's our charge nurse for ICU, and Jenny Lago, our matron from theatres. Real outstanding stars from the hospital, and I'm delighted they got some public exposure because they deserve it. Anyone that's on Twitter or listens to Radio 4 will have come across Rupert Pearce. Rupert's a colleague of ours who works at Royal London, but an intensivist, and has actually proved his worth as an urban poet, because he's been writing some beautiful stuff recently and really moving stuff. And then finally, in the New Year's Honours list, our chief exec was given a damehood, so Alwyn is now Dame Alwyn, which I think is great recognition of all of her work, not just this year, but all of the work she's given to North East London. But also more locally and more importantly to us, Anne Claydon, who's our nurse consultant in diabetes, and Wendy Olayiwola, who's one of our midwives, were both given British Empire medals. Real recognition for proper work done in Newham for the people of Newham. So that's been really delightful for us to be able to congratulate them. And then lastly of all, we've now done this twice, you know, and I really, really hope in my heart we never have to do this again. But if we do have to do this again, we're better at it than we were the first time, and we're a lot better at it than we were before we even started. So we know we can do this again if we have to, and we can do it together. But let's keep everything crossed that this is the beginning of the end. Happy to take any questions now or later if you'd like.
Thank you so much, Andrew, and thanks. That was a really really comprehensive, and it's just so lovely to see our workforce recognised. And it's just, I know that all of our workforce are working so incredibly hard. So yeah, I think, can we take the questions at the end, because we're running a little bit over, unless anyone's got a really a question they want to shout out right now. But I think if we do right at the end, that'd be better. Okay, so if we could just move on to Agatha and Jackie then, who are from LAS and who have kind of given their time today. I'm so happy. This is the first time we've had LAS on one of our webinars and meetings, and it's such an important relationship. So yeah, thank you for joining us today.
Can we just introduce also, we brought a colleague Tiffany along who's been really involved in the work across BARTS, so she's joining us also.
Hi,
Yes.
Good evening, everybody.
Hi, and thanks for having us. Really, and it's actually, you know, really interesting to hear everything that's been happening as well across the system. So thanks for having us.
Yes.
So really what we want to talk about is the COVID impact and what we've been doing in London Ambulance, what it's kind of felt like on the ground. As you know, we cover both 111 and 999 and ambulance services. So we've seen different impact from different angles, so to speak, but also the interface with all the other services across the system and how we work together. So obviously we know wave one was quite significant at the beginning of the year. The level of demand went up quite significantly in both the ones and the nines. We saw a tripling of our call volume, and we're used to 2,000 to 3,000 calls a day. We were in excess of 5,500 to 6,000 in the ones, and the 999 we're used to about 4,500 to 5,000. We were getting 8,000 to 10,000 calls a day. I think coupled with that was the uncertainty. It was all new. No one knew what was happening. Everything was changing so quickly. A lot of the comms was quite vague and pointed everything into 111, which may not necessarily have always been the right place. And obviously, as an in-hours GP myself, it wasn't, our patients didn't really know who to access, when to access, etc. But also the rapid changes in guidance, and we counted in across our 1s and 9 services that we had about 20 plus changes in the space of a couple of months. So every day something new was happening. We were having to update staff and make sure people were on top of things. But it really, that surge, that peak really just kind of burnt people out. Obviously, we did quite a few different things at that time quite rapidly. We set up a separate COVID queue in our 111 service so that patients with COVID symptoms could be managed differently, but also so that it didn't detract. We have lots of sick patients calling us anyway in 111 and in 999. And as you know, we validate any calls that come through requiring an ambulance from the 111 call handlers or requiring an emergency department and things like that. So there are some sick patients, and they were blended into a queue of over 1,000 patients, with patients who were COVID, worried well, asking about swabs, asking about all kinds of things. So there was a big mixture. We the shielded patient flags were set up, so that was able to pull the shielded patient flag out of primary care operating systems, which was really useful because it allowed us to be able to manage these patients differently, get them to a clinician really quickly, but also to alert services where we were referring onwards. There were new ways of working across the 111 service, but also how we interface with all the other providers across the system, and obviously expansion of our call centres across both 999 and 111 as well, and utilisation of different groups of staff. So we had paramedic students coming in and carrying out telephone assessments with support and supervision, and created a 999 health advisor role, as well as having a COVID clinician role, which we could rapidly onboard and train. I think one of the things that really made a difference in that first wave was the support from the other providers across the system, and this was urgent care, out of hours, the extended hours hubs, etc. That standing up of that additional capacity, where actually we could pass patients across, refer patients across, that could be managed differently. And I think what enabled that was the fact that we were all moving into a normal process of telephone and video consultation across the system. So when you're referring them to another GP in a hub, we were doing the same role. The GPs in the 111 CAS were doing the same role in terms of doing that telephone and remote assessment and trying to work out what the right thing for that individual patient was. And I think that was a really good whole system collaboration, and it really built those relationships across the system. But also the acceleration of technology, which was around being able to send text messages to patients from 111 around, and our 999 clinical assessment service around their appointment times if they had one, or when they would be, and also the worsening instructions. So the safety netting advice that was given, we were able to translate that into something they could access on a text message, but also video consultation, remote working, which were all things that we'd been talking about and gradually progressing in the background, but the COVID made it happen faster. And I know in primary care as well, that happened for us as well. And then obviously increased access and direct booking. So one of the challenges was that our 999 clinicians didn't have access to the same clinical pathways as our 111 clinicians. And it's been discussed on this call as well that, even in hours, out of hours, and extended hub primary care, the access to services, the ability to book in, the ability to refer, the ability to see what's available is not there. It's not equal. So there's something about how we kind of managed to increase that. We managed to create that access across our 999 services as well as our 111 services, but also the introduction of GP Connect and being able to refer patients where it was in hours to be able to speak to their own GP who knew them better. And then finally, obviously, things like collaboration, and I've talked about that across the system, but 111 First, which I'll talk about in a minute, just really kind of brought that together. And one thing that happened in Northeast London that I don't believe happened to the same extent anywhere else was that we the system came together into a restoration board which mirrored the Pan London Restoration Board, and that really got different providers from different bits of the system talking together and becoming one team. And it was all about the patient and how that patient flowed through our systems and how we could support each other. But we learned so much about each other that a lot of good things came out. So and also obviously in the nines as well, our collaboration with our other emergency services, so the fire brigade and the police as well. So actually looking at how we worked across the system with other providers and built something that worked for all our patients. Just in terms of GP Connect, these are the bookings. So North East London was one of the best utilizers, I think is that the word, of these of GP Connect, and it just shows how it gradually grew over the months. I think it dropped a little bit off in January for some reason, particularly in City and Hackney, which was our lowest, but just showing that, you know, the utilization of those appointment slots across our primary care services. Shall I hand over to Jackie? Did you want to talk a little bit about 111 first and the concepts and the challenges?
So yeah, just to reiterate what Agatha said about North East London and just the response from the whole system. In wave one, I think it was something like the 26th of March, we just realised there was like 600 calls waiting to come through across London. And literally within 24 hours, we had the whole of North East London system stood up with extra capacity across it. And we saw engagement with general practice and our hubs and out of hours. And it was the quickest response across London that was seen, and it was maintained, and then we saw the same again in wave two. So you know, it was really commendable what happened in Northwest London. One of the things that came out of the first wave was areas that we needed to look at. There was a need to maintain protecting our EDs and stopping any unheralded patients going down, and to also protect our ambulances. So the programme of 111 First was adopted, and there was quite a lot of challenge around the name, because everybody, including us, actually feel that the first point of contact for the patient is general practice. That's where they should be going first. It was voiced, it was escalated very high, and it was we were told that basically that was what it was going to be, and you'd have seen the adverts on the telly, and that was the slogan that was adopted. But it was very much felt by all of us, I think, that we didn't want to encourage patients ringing 111 first. It should be general practice, but that was the theme that we ended up with. The key points that were being highlighted were about how we validate anybody that thinks they need to go to ED or to a Cat 3-4 validation that needs to be validated. And the other thing was to support our crews on scene and giving them access to clinicians, but also just to work as a system to identify ways of having direct booking, and as Agatha said, moving away from the 111 and 999 split, so full integration. So irrelevant of what number you rang, you ended up with the most appropriate service and appropriate level of care. And that was a lot of the work that we focused on over the last few months. Agatha, do you want to move on?
Yep.
So some of the barriers there, just highlighting again, I'm conscious of the time. So moving any restrictions and being able to book things into the right place, making sure that we were booking into ED or UTCs so that these services knew who were coming, they knew why they were coming, and it was all managed in a way that was safe for the people on site and for the patients. Limiting face-to-face, so all our downstream providers moved to telephone and video consultation, as did we, and also within our 99 CAS as well, they were using video consultation there too. And then the other thing that I don't think we quite tackled, it's still a bit of an outstanding one, I think, and that is the management of unregistered or visiting patients. So Newham, as part of North East London, is an area that gets a lot of people passing through, and a lot of unregistered. And I don't think we completely tackled that one. So it's you know, the work hasn't ended, even though we saw a wave to. On to the next one. Should we just talk about this one?
Very briefly. So this is, I mean, Jackie's mentioned this. This is just the flow chart that shows what it is. But I think that being able to herald patients and direct book them into a arrival time with an emergency department, an urgent treatment centre, etc., was really useful, because at least people could in those departments knew who was coming. If they were shielded, we could, you know, that flag would go across. But it allowed that workflow to be managed at that end. The addition to that was, and I think what really kind of grew in North East London that didn't grow anywhere else, was hang on, I meant to talk about the beach, but I'll come back to this one, was around the beach. So the beach concept was really around starting that episode of care ahead of the patient arriving, and even maybe being able to intercept that. So that was a piece of work that came out of the restoration group, where the ED consultants were invited to a session at our 111 call centre, we discussed 111, we discussed 999, we went through the NHS pathways algorithm and how it worked. And actually out of that discussion was born the idea of the beach, and what really that was around was being able to refer the patient who would be assessed by a senior doctor or consultant or advanced practitioner within the ED department remotely before their arrival, and that would allow them to be able to start that episode of care if required, start to organise checks or tests or things that the patient might need. We had some good news stories around patients who I think there was one patient who required some special equipment and things like that, and that could all be arranged. They could find it within the hospital before that patient arrived, and another patient that arrived and had already had their CT scan booked. They had a head CT booked, so while they were waiting for the result, that's when they were being clerked, and by the time that finished, the result was back, and their time in the service was reduced. We also had the ambulance beach, which was around again our clinician to clinician conversation between our ambulance paramedics and the consultants in the hospitals. And really, again, it was around expediting that handover at the hospital, starting that episode of care for the patient ahead of time, and being able to provide that right care, but also to expedite that transit through the hospital system. I don't know if Tiffany or...
I just want to say that they started in Royal London and then were rolled out to the other BART sites because they were quite successful. Tiffany, sorry.
No, not at all. Just to add to that, we're up to now 1,000 patients who've gone through the ambulance side, and we're averaging around 50% which are being non-conveyed. So they're being referred on to other services or being attended by the physician's response unit. We've still got a lot of data to analyse to look at the impacts on any potential ambulance delays that might be happening for those that are still going on to hospital. But it might look like time is being brought back into the system with the expedited care through the hospital.
Brilliant. Thank you so much, Jackie and Agatha and Tiffany. There's really just so much work going on in there that we're not aware of sometimes. Absolutely. And I really hope you can join our future meetings and we can develop our relationship. I mean, for me, we are running a little bit behind on time already. No problem. But it's really about actually what can we do if there's any ask from primary care that would make your life easier, or the other way around, then that's kind of the conversations really that we wanted to start. There's been a little bit of on our end, a little bit of some anecdotal concerns that we've had, that sometimes patients with low SATs have been at home, and they're not being conveyed to hospital as well, and we've picked up on those, but it's very difficult to really bore down and find out what's happening. Was it the patient refusing? Was it your pathways? So these are the kind of conversations that I'm really hoping that we can start having as well.
Is it possible, Kavita, if I just cover this, because I think this is the answer. This is where we were trying to answer those very questions. I think is the thing that for us that was really key. Yeah. So I think for me, and this is obviously speaking as a GP myself as well, I think there is something about how we interface, particularly with the 999 element, because I think the ones element, actually a lot of that is GPs. There's primary care kind of clinicians in there, but I think with the nines there's a few things. I think one of the first things is referral and using of the healthcare professional line if you require an ambulance referral for your patient. So there is a healthcare professional line, which if people don't have it, we can make sure that everyone gets it. But I think one of the key things is recognizing that when we utilize that line, the crews are bound to convey that patient. They don't kind of get a choice necessary to assess the patient and leave them at scene. If they get a referral from a GP, they will never override that GP. So it's really important to also keep in mind the ambulance response program and the categories, and that understanding of what those categories are and what response that we really want for our patients. We do have the 999, we call them the ECAS now, we used to call them the clinical hub, but these are the senior paramedics within the 999 control room, and they can support with decision making around the priority. But the key one that people get stuck on is the category 2 and category 3, because with category 2 you've got an 18-minute response, and these are your time limited patients, stroke, sepsis, cardiac sounding chest pain, etc., that need to get somewhere very quickly, and severe COVID reducing SATs, they need to get somewhere very quickly for help. Category 3 are still sick, but actually we have a bit of a longer window to get to them, but they're still quite urgent. And I think sometimes we just want a very quick response, so we pick a category 2 instead. But what I normally say to colleagues is your cat 3 is the one that if you were on a home visit, you would be able to go back to your surgery while they waited for the ambulance. The cat 2 is the one where you would stay with them. The same thing as if in your clinical consultation room, your cat 2 is the one that you would delay your clinic for. The cat 3 is the one you would put in a side room and intermittently check on. So the key thing is being able to refer at the right category, but safety net very heavily, and be able to tell the patient that if they do deteriorate, that they must call back 999 and tell them what's changed, because they will upgrade themselves. But don't not to request a higher category just in case, and also not to kind of utilize the just to check up type thing, because the crew will convey because it came from a doctor. I think the other thing is around crews calling us in primary care, and obviously I know we do try our best to get back to them in time, but really sometimes that conversation can happen so that we can understand if the patient is discharged on scene or didn't want to go in or anything like that, that we can have that clinician to clinician conversation and agree a safe process together. Because sometimes by the time we get back to the patient, either the crew have waited a long time and then we've delayed them getting to other patients, or if they've waited too long, they've left, and then we don't get that conversation, we don't get that understanding, and that probably may impact on our decision making. The crew will also give you the details about observations and results, etc., of things they've done. They would have done 2 full sets of observations, probably an ECG, etc., and a full clinical assessment, and that can help us with our clinical assessment. We also have access now to EPCR, which is almost like our electronic discharge summary. I wanted to get a screenshot of that for you, but I can send details about that later. But for those who aren't already using it, this is the first time as a GP that if the patient wasn't conveyed, I can still access the consultation notes of the crew, including all the obs. I know exactly what happened. I know what they were told. I know what the outcome is. And then finally, what we're doing as well to try and improve that working with between primary care and the nines is we've introduced an ECAS GP role. And this is where GPs are coming into our 999 control room and working with our 999 clinical assessment clinicians in a similar way to GPs working in our 111 service. But that way they can support the validation of these Cat 3-4 outcomes, ambulance outcomes. We can support the crew advice and crews calling into 111, and we can also provide clinical advice and support for the people in that call center environment. And that's really building those relationships, because there's the skills that each primary care GPs and paramedics have different skills, but actually we learn so much from each other. So I think those are the kind of key points really that I wanted to bring across.
Thank you so much, Agatha. Thank you. I think there's so much to talk about, isn't there?
There is. We'll probably have to do another session.
We may need to, and kind of really focus on how we improve that interface. But I just want to go on to Dr. Helen Parker now, just to kind of give us a real feel of what's happening on the A&E front door, and then we'll move all the way through to the end, I think, and take questions at the end. Hi, Ellen. Thank you.
Hi there. I'm going to try. There we go. So thank you very much for putting me on directly after the people who've got a really fancy slide set.
I don't think Jamina's joining us today. Is that correct?
Yeah, I've messaged her, but I haven't heard back from her.
Oh no. Okay, don't worry. We've got you at least. That's great.
Yeah. So I'm sorry, I don't know what happened there. So this
no worries. I was just checking she wasn't on the call, and I'm ignoring her. Sorry, go and carry on, Helen.
So this is just a bit of a whip through with very amateurish looking slides now. I'm definitely going to have to work on that for the next time. So onto the next slide, just a little bit of coverage of what is working well. So I know that Claire did a really nice handover about the home monitoring for us as clinicians in the emergency department. It just adds such a brilliant layer of confidence for the discharges that we're making, that we're not completely throwing them into an abyss, and that they are getting followed up and reviewed very regularly and very thoroughly, and coming back if necessary. Our ambulatory medicine pathways are working quite well, and we're hoping that there may be room to expand that in the future. At the moment, one of the really big problems that we have in the emergency department and the hospital as a whole is just the physical space. We've got fireworks going on, and so our ward spaces are limited. But we have other areas that are having to be maintained and done up. And so they are also being closed intermittently, and that's also putting a real pressure on the physical space that we have. The beach, which Agatha and Jackie talked about a little bit before, has been something that's been excellent for us, and it has kept people at home who otherwise would have come to the emergency department. We did have a period of time where we were trialling physically running that at Newham, but we just found that we were unable, with our other pressures on staffing, to really staff that adequately. And so that process has been centralised and has run out of the London at the moment. But as so much is changing so quickly, I'm sure that, you know, as things settle down from a COVID point of view, that might well be something that we revisit, how we staff that, because I know that you guys in primary care have been doing telemedicine and virtual consultations for ages, but it's really new for us. But it's certainly not going away, and I think it's something that our trainees and our established consultant body actually will remain interested in, and I think that there's a lot for us to learn. So still some challenges that we have are patients being seen, being directed in by GPs that could really have been managed in the community. So yesterday evening I spent 3 hours on the front door seeing patients who walked in off the street, and 70% of them told me, so I realised that there is miscommunication and different interpretations of conversations that do definitely occur, but had told me that they'd been advised that they needed to be seen by someone, and so that they needed to come to the emergency department. So there are pockets of the community where, you know, there is still some work to be done. Also last night we took quite a lot of ambulances that were from out of area. So one elderly patient who'd been discharged the day before from Queen's Hospital had been picked up by LAS and then brought to Newham. That creates several layers of problems for us. One is the physical space in our department, which is very, very tight at the moment. Two is that it takes our doctors a lot longer to see these patients, because they often spend several hours on the phone to other hospitals trying to get the key information that they need to be able to treat them appropriately. And then once they are admitted, then they create a real difficulty for our inpatient teams in discharging them, because again, they're trying to liaise with other boroughs to arrange the social care packages. So they are a real difficulty. And, you know, I know that we're all doing our best to try and address those issues. Next slide, I think we can just skip. It's got some numbers on it. Nobody wants numbers at this stage of the evening, so we can just go on. So in the department, we are seeing more patients on AGPs, so more patients on Optiflow and BiPAP. And at the peak, that was a real issue. And we struggled at some points to have enough machines to deliver those AGPs. They were relatively brief, and we were able to resolve them, but there were a couple of shifts that felt quite lively in terms of deteriorating patients we wanted to put onto CPAP, but struggled to find the equipment to do that. We're seeing a lot more deaths in the department this year in comparison to the same period of time for last year. And we are seeing a couple of phenomena that I, as a clinician, have never seen before. One is people who appear to be relatively well, who are coping very well on just a couple of litres of oxygen or 35% oxygen, not even on CPAP, who we are going back in an hour after a set of reasonably reassuring observations to find dead patients in cubicles. I've had several complaints, understandably, from relatives, and have had to make a lot of telephone calls to people to try and explain this. As a doctor, I have no explanation. It's a weird thing that before COVID I'd seen a handful of times in my career, and at the peak of COVID in the kind of middle and late part of December, we saw it, you know, once or twice a shift. Something that I don't understand. The other thing that I really don't understand is the patients who walk in to the department and, you know, are complaining of feeling short of breath, and you put a SAT probe on them, and their oxygen saturations are 75%, and they're still alive and talking to you. So I guess that there's something there about how rapidly people desaturate. I know that when we're doing intubations, if somebody desaturates to less than 90% as part of an intubation, we all get very excited about it. But it seems that if this is a gradual decline and, you know, has happened over hours or days, people can tolerate much lower oxygen saturations than I ever thought was possible. We are struggling to offload ambulances still. As Andrew said earlier, it's not as bad as it was, but certainly last night we had a couple of patients who were in the ambulance for more than an hour and a half while we were trying to find space for them in ED. One thing that's happened more times than I am happy with is that we are put in a position as clinicians where we're asked to make a choice of two things and neither of them are good choices. So, for example, do you offload an ambulance into an empty cubicle that doesn't have a member of nursing staff assigned to it and risk the nursing staff getting so stretched that you're putting more patients at risk? Or do you have the risk of having to leave somebody in the back of an ambulance for a prolonged period of time whilst you try and offload and decompress in other areas in the department? So for me as a clinician, neither of those choices have felt particularly comfortable. And I think that that's something that we've all seen in COVID, is that we are frequently put into positions where we're being asked to make a choice between two things which both feel pretty rubbish, really. Attendance is starting to increase. Obviously, that's a lie. Not what I meant when I wrote that. I was obviously distracted. Was in comparison to the first wave, when we weren't really seeing many walk-in patients at all in the department, and so we weren't particularly stretched. This time we are stretched. And, there have been quite long waits to be seen. There have, at times in the emergency department, been quite long wait for triage and quite long wait for assessments to be done, which has also felt uncomfortable. And the other thing is that everybody's tired and over it. Everyone's fed up of quarantine and everything being shut. Everyone's tired. Everyone wants a break. Everyone is under stress at home with either not being able to see their relatives or children being at home for a long period of time. The community don't want to follow the rules anymore. And so that is a kind of an additional stressor to what we saw last time. So moving on to the next slide, this is a personal favourite of mine. What you're looking at here is an actual surgeon in the back of an ambulance going out there to do an assessment on one of his patients who we were unable to offload. So I personally have had patients that I've seen in the back of an ambulance. I've got blood tests done from the back of an ambulance. I've got the results back, and the patient has come in and had a chest x-ray and then gone back into the ambulance and then been discharged from the back of the ambulance by taxi back home without ever coming into the emergency department. So managing to tempt a surgeon into the back of an ambulance was a high for me in the second peak. The next slide just shows a bit of a demonstration of something else that we've been doing at Newham, which has been...
My slides aren't moving, Helen. Is that for anybody else as well?
Oh, sorry. Mine are moving.
Mine are fine. Yeah.
Oh, okay. It's random then. I was thinking. Sorry, go on, carry on then. Don't worry. So at least they're moving for some people. That's fine.
So this is a picture of some of our very happy and cheerful volunteers who have set up a tea stall in the ambulance bay, which operates as often as they can between 2 and 6, and they staff it with stuff that they bake themselves or stuff that they manage to get local businesses to donate. So baked items, tea, coffee, and that is to offer food to paramedics who are bringing patients in. And this kind of started when paramedics were having to wait longer to make sure that they weren't going hungry or thirsty while they were there. And also staff from the emergency department, when it's less busy, are able to come out and have teas and coffees. And the response to that has been really good. I think that the paramedics have really appreciated it. The ED staff have really appreciated it. And actually the volunteers have all absolutely loved doing it. So these are all people who don't work within the medical field, who have said that they feel like they are feeling tired and frustrated, stuck at home, and the opportunity for them to feel like they're doing something for the front line has been really beneficial for them. So that is something that has been a success, which was started by Emma Young, a colleague of mine, and I'm sure that will be ongoing for the foreseeable future. The other exciting thing that's happening at Newham on the next slide is that our new build, which is called the Deck, because my lobbying to get it called the Helen Parker extension has been declined for some reason. I don't know why. So it's been called the Deck, which stands for Day Stay Emergency Care Centre, which will be offering same-day emergency care. So at the moment, we really are struggling with our nursing staffing. Medical staffing is not too bad at the moment. So how this works will probably evolve. It will probably be used at the moment initially for the rapid diagnostic pathways that we have, for example, pulmonary embolism and for renal calculi. But we've got 8 spaces there which we can flex to need, and that's all looking really new and really shiny, and so that's exciting. And we are hoping to open that. No, we're not hoping to. We are definitely going to open that on Monday. So that's going to be quite lively this weekend, making sure that that's all stocked and ready to go. Yes. And then final slide, you'll be pleased to hear. One of my colleagues who's a lot younger than me was doing some very fancy yoga moves and tried to teach me a move called the crow, which is way beyond my fitness level, but it was very nice to have a lie down on the carpet for a while, which is the closest to yoga I'm ever going to get. And certainly in the not too distant future, I am very much looking forward to a long lie down on the carpet.
Brilliant. Thank you so much, Helen. Thanks for giving such a vivid picture. I think you've just, it really kind of, brought the images of what A&E is like at the moment, and some of the decisions you're making are so difficult. What you were saying with the ambulances and the nursing, and whether you keep them in the ambulance, it's just really, really difficult. So thanks so much, Helen, for that. We need to move really swiftly on, because I don't want to keep people away from their evenings and their families. So if we could just move on to Rajesh then, and then we will finish off with Kate. I don't think we're going to get much time for questions, actually. So if anybody does have any questions, can you just please put it in the chat? Thank you. Rajesh?
Hi, I'm Rajesh. I'm one of the GPs. I've been working in Newham for 15 years now. And I have had the privilege to sort of be around and experience COVID firsthand from both sides. As a doctor GP doing 8 hours, extended hours, and in the first wave, and then in September I was ill with COVID, and I've had the good opportunity to be looked after by Newham Hospital and the team at Newham Hospital A&E department, and Andrew, their team, obviously are fantastic looking after me. And since obviously recovering, I think it has really made me feel that as GPs, obviously we could probably do better in trying to kind of help, like everybody's coming together, like the London Ambulance Service, the 999 service, and all these services are coming together. We can do better as well. And I tried to get involved with vaccinating when it started, and then I got involved with the ED validation with LCW, the out-of-house provider for London, Central and West. So I do ED validations for them. And also I have been working with Claire as an in-reach GP, trying to help discharge some beds from Newham Hospital. So that's the background. And I would like to sort of go through the slides quickly now so that we can actually waste much time. So the spectrum of patients that actually we see in primary care are varied, and I've tried to sort of list them here, and they are asymptomatic, and then I've got this little degrees of illness here. Now that's from my own perspective as well. Obviously I've classified this. I've taken some information from the National Institute of Health from America, and we have mild illness where you've got patients who have got the flu symptoms, but they haven't got dyspnea. But sometimes, as you already know, some of these patients can have silent hypoxia. Then you've got people who we can put into a moderate illness category. They have all the symptoms of flu, but then their SATs are okay. They're more than 94. Then you've got the severe ones who've got the normal symptoms of flu, but they are more dyspneic, and the SATs are less than 94. And then you've got critically ill who are dyspneic and delirious, whose SATs are less than 92. Now, when you're doing a consultation from a GP point of view, I mean, we see these patients in different scenarios. From a primary care perspective, you might be seeing them with no access to these SATs values, to their pulse, how fast their pulse is, we don't know how fast their breathing is. So an oxygen saturation level on its own is no good for me. We need to put everything into context, which I will explain by going through the next slides. So as I said, from my primary care point of view, with no sort of access to any of the ancillary sort of services which have now been developed and are going to come into play very soon, like the home monitoring service, the self-monitoring clinics, the video consultations at ED. When I do the ED validation, we go video consults. A lot of things are improving the right direction so that we can assess these better, so we can send them to the right direction. Now, the next slide is the list of people who we need to safety net in primary care. So not just going by GSAS or not just going by how what the background is. We know that everybody is affected by COVID. If you look at that list, you've got the obvious sort of high clinical risk people there, but at the bottom you've got young people with no underlying comorbidities. Now they might be living with somebody who is living with a vulnerable person. So when we actually are taking a history, we need to make sure who are they living with. And even if they're not living with anybody else, a lot of young people are being affected, especially in the second wave we have seen. So especially pregnant ladies who are more than 28 weeks old, they are more at risk as well. So anybody we are consulting, we have to put everything in context. So these are people who can deteriorate quite quickly. Somebody who's got a history of DVT and PE is quite relevant in COVID, which I will explain when I try to go through the pathogenesis of COVID quite quickly. So anything that you are talking to, anybody you are talking to, when you're trying to assess people, always put into context the background of that particular person, and even if there's no background, high risk, still always safety net. Now we have seen some non-specific sort of presentations as well, especially in older people, the housebound people. Well, it ranges from just feeling like lethargic, lack of appetite, non-specific symptoms, which previously we might attribute to a UTI or a chest infection. But in COVID scenario, we have to think otherwise. We need to safety them more and try to refer them on to certain services which will help to monitor them better. An antibiotic does not solve everything, so we need to go further than just prescribing, and we need to safety net them better, because now we got these different services. Then we got the children who can be really ill. So not a big percentage. Most of children are presenting with rashes, and rashes can vary from vesicular rashes like chickenpox, or they can have like a measles like a rash, and they can have diarrhea. But some children can be really ill. We need to identify these children. So forget about the age group. Any child who has got like severe swelling, redness of the hands and feet, or mucositis, conjunctivitis. Imagine the picture that when you have a really ill measles child. I'm sure we have all seen those pictures. So if the description fits in a picture like that, or with like flaking of skin at the tips of the fingers or severe stomach pains, think COVID, because that's how it's presenting. It's rare, but it's still happening. Then we get these COVID toes, where obviously it looks just like a chilblain. It's a pseudo chilblain. We think it's vasculitis. At the moment, the main presentations are about 2 to 3 weeks after the flu-like illness. They present with pains in the toes and the fingers. It's happening across the board. Children, adults, everybody's getting it. And we are seeing the main complaints are either pain, either the feet, the toes or the fingers are cold, or they're having a flakiness. And sometimes they have actually slight bluish tinges as well. Now, there's no guidance as to how we can treat them, but we can't give them like, nifedipine and things like that is not indicated at the moment, but it might come in the future, we don't know. At the moment, how we are treating it is pain control, keeping them warm, using some hydrocortisone cream for the itching. That's how we are treating them. Whether to use a rectogesic or something like that, like a vasodilator cream, we don't know. So at the moment, we're not using that, but it might come in the future. And again, hair loss post-COVID. So this is happening about 6 to 8 weeks post-COVID. A lot of people are losing their hair. So if there's a history of COVID, losing the hair after 6 to 8 weeks, very unlikely that you need to do any more tests. Just reassurance is needed. Now, the next slide. Now, this is a COVID timeline. It comes with a disclaimer that anything can happen at any time. So always be on your guard with COVID, and it can happen to anybody. But most people, if you look at day 14, that's the average recovery time from mild disease. Most people, 80 to 90% of people will get better by day 14. Some people, about 10%, will get ill and will need hospital admission, usually between 5 to 8 days. So if you look at that between the slides, between 5 to 8 days is when some people, about 10%, might get ill. But as I said, always in COVID, safety net and make use of other accessory services that you've got. Now, I'm trying to do a pathogenesis of COVID from a GP point of view where I can understand. So we know that, and this will also help us to understand how we are treating this. In the early stages, we have got viral replication inside the cells, like in the first week or so, and that's when we are using remdesivir. Remdesivir is not used in later stages, in the early stages. In the later stages, we are having an exaggerated immune response and tissue damage, and this is happening in the lungs and in the blood vessels. In the lungs, what is happening is it is causing the bronchioles to get damaged, so oxygen diffusion is not happening, and dexamethasone will help here. And that is why in the recovery trial also it is proven that you can use dexamethasone to reduce this damage that is happening and improve the response to the illness. Another thing that is happening is, just because of the exaggerated immune response, we are having thrombi, which are basically small clots which are forming because of artery getting damaged. And this is happening everywhere. This is happening even in the peripheral branches of the lungs. So basically, you can have a small artery that is getting damaged because of the immune reaction at the periphery of the lung, and that will cause chest pain. It can cause hypoxia, shortness of breath. But sometimes you can have a big sort of clot in the leg that's going to the lungs, blocking the big artery as well. So sometimes the symptoms might be very subtle. So you can have somebody complaining of non-specific chest pain and shortness of breath, very mild, but it could still be a thrombus in the peripheral artery of the lungs. So be careful when somebody is complaining. Like, it's not normal for them to complain. They've been normal before, and suddenly their work of exertion has gone up. So we need to make sure that these cases later are not found dead. So when somebody is saying that I'm slightly more breathless than normal, I've got a bit of chest pain here, not specific, nothing classical, beware. This could be a small thrombus in a peripheral artery in the lungs, which can then obviously cause more problems in the future. So dexamethasone and anticoagulation both will help here. Okay, now I'm going to the next slide. Now, as I said, the management is very simple for most people. Now, we have to highlight here the day of the symptom is very important. The day when the symptoms started, as most people deteriorate after about 1 week. In the first week, for most people, all that's needed is normal flu symptom control. So control the temperature, good fluid management, because we know that there's a pro-throat, the chance of clotting is more. So make sure 2 to 3 liters of water. Obviously, you will have exceptions when you've got patients for heart failure patients and stuff. So we need to be aware of that also. Make sure that for fluid management is appropriate. Breathing exercise.
Hi. I'm just seeing that we've got 24 slides here. So I'm just thinking also is how we're, just being careful with the timing. And I don't know if we're going to be able to do justice to all of your slides that you've got at the moment. Sure. So and we've got Kate that's got to speak, and I really do want to finish by 7:30. So, I mean, this is just really, really important stuff. And I'm just wondering whether if there's any key messages you could give. And then what we'll do is, I know you've prepared it, so you put a lot of effort and preparation into this, is whether we do another webinar just focusing on this, because there's so much in this. Yeah. I'm just thinking it could have been a webinar in its own, really. So, if there's anything, key messages you want to give over the next, and then I do want to just bring Kate in just to give, she's taken her time to just give a quick update on the, So is that okay, Rajesh? I'm really sorry to do this to you. It's just the timing, I think, is just going a little bit over as well.
Absolutely. I think
we're being very,
I'm just going to go next 3 slides very quickly, so we can actually start. So basically, antibiotic usage. So it's a viral illness. It does not need antibiotics. If there's temperature after 7 days and we feel that is needed, like for secondary bacterial infection, and that is the antibiotic that we can use. And steroids, we can still use steroids for COPD and asthma as indicated. Dexamethasone is only being trialed in secondary care. So at the moment, it's only for secondary care when there is oxygen issues. But we are seeing ill patients, housebound patients who sometimes are not able to go to a hospital. So maybe in the future, we might be able to use dexamethasone if some more studies come out in the primary care. But I'm sure a lot of GPs are still using dexamethasone in primary care, which is no problem. Yeah. Now, anticoagulation, this is very important because a lot of people are finding that they're coming out with all these anticoagulants and what to do with it. So most people who are in hospital, they are having their thrombosis and bleeding risk and are giving low molecular weight heparin. Then you got the ones who have actually got evidence of PE or a very high clinical suspicion of PE, and they're put on the treatment dose of low molecular heparin, and then they usually continue the NOACs for three months afterwards. There's an intermediate sort of thrombotic risk patients where it says if the seriousness of the illness is high and the BMI is high, they give a double dose of the prophylactic dose after assessment in hospital, and they are usually likely to receive 2 weeks post-discharge oral anticoagulation only. So there are 3 different categories of anticoagulations. And again, I think that's most of the slides, and I think there are many more slides, but as I said, we can't probably finish all of it today. Yeah.
Rajesh, we've recruited you to come to our Nurses Forum and to do a couple more webinars. Is that okay? I'm so sorry. I just think we're not doing your slides justice because there's so much good information in here. So can we, oh yeah, and also to the clinicians at LAS too. I think you're going to have a busy few webinars to do after this. Rajesh, but I think let's plan another one for this properly and then let's do it real justice, I think. Thank you so much, Rajesh, for preparing all of this. And as Amira said, if you could go to the Nurse Forum and present on this as well. Thank you so much, Rajesh. So can we just move on to Kate and then yeah, and then if we could, yeah, thank you, Kate, for holding on to the end as well.
Yes, so I'm Medical Director of Community Services, but I brought Helen, who's the Deputy Director. She's going to talk about the Integrated Discharge Hub, and Ram is going to talk about telehealth. He's the service lead. Many of you will know both of them. And maybe because of time, I'll ask them to concentrate. We've only got 2 slides anyway, but I'll ask them to concentrate on the any new developments, so the things we really need you as GPs to know.
Thank you so much, Kate. Thank you, Helen.
I was going to say, and I can scoot through mine very quickly. Have someone got the slide up, or do you just want me to talk to it to myself? I can put it up here anyway. I was going to tell you about the Integrated Hospital Discharge Hub and just give you a brief update. You probably are all aware of the fact that this has been going now in Newham Hospital since March last year. And it's a collaboration between East London Foundation Trust, Barts Health and London Borough of Newham. So all 3 providers are in there, and it's to improve the quality of discharges across the hospitals. They're in every hospital now, and I have to say in Newham we've basically stuck to the government guidance, which was revised in August 20. So if anyone wants to check what we're doing, look in the government guidance. We're pretty much following that. We've actually processed 4,132 referrals since April last year, and we're getting an average of 22 a day complex discharges at the moment. We're hoping that the hub will be permanent. The government has mandated them now. We've got a permanent manager, and we're looking for permanent posts. So if anyone wants to come and work in our hub, we're looking for therapists, nurses, and the like. I won't tell you that we've reviewed our standard operating procedures and to make sure they're compliant with the Mental Capacity Act and safeguarding. Interestingly, we've also got some short-term funding for a pilot of a mental health discharge coordinator, because I think that's probably really important to tell you, in that in Newham we've had some concerns about discharges to people with dementia. So this is hopefully going to help us improve those across the board. So we're looking forward to that. I'm popping between my pictures so I can see you all. The other thing is we've had some processes agreed with Newham Hospital about how we report discharges that don't work so well. So that's really positive. And we've had 2 quarterly patient surveys done now. Probably the
overall people are satisfied with their discharges. What they don't like is waiting once they know they're going to be discharged. So that's a quick scoot through the integrated discharge hub. But if anybody wants to come and talk to us about it or any more information, I'm happy to do that. I'll pass you over to Ram for the second slide.
Helen, I can't see your slides. Can everybody else see them? We don't have your slides.
I was going to say we sent them in to you this afternoon.
But I think there were some changes afterwards. So
all right, I can probably put them up. That's what I've just told you. So
yeah, brilliant. Okay, brilliant. We didn't put them up because we thought there'd been some changes. But that's sorry about that. Yeah.
Don't worry, that's mine. If you want any information, but I'll put Ram's up there so he's got that to talk to you about. And it's basically the hospital at home model. Can people see that now?
Yeah. Yes.
Thank you. I'm sharing. Okay, go on.
Thank you.
Okay. Brilliant, thanks. So I'll just try and keep it really short. So yeah, I think most of you must have heard about ELF telehealth services. We've been providing the telehealth services for several years through different layers within the system, and ever since the first wave started, we've been sending we've sent some comms to the practices. This is just mainly to reduce the pressure in the system, and so we've also sent some guidance for the GPs as well. So basically the main aim is to observe the vital sign trends and respond to the trends remotely, and basically it just serves as a tool for both the clinician and patient to decide on self and future health management, and basically enhance analyzing trends for the GPs and consultants and senior practitioners in making clinical decisions that's based on the available evidence with the monitored data. So it's not just purely the vital signs. There are a lot of question sets personalized according to the patient's needs. So when we first started, we used to offer services only for patients with long-term conditions, but currently we've moved on so much. So currently we support patients with learning disabilities, patients who are on a long-term catheter, offering them support, and also patients who are at risk and of developing a pressure sores, and patients who have healed the pressure sores as well. So we are also providing our services for delivering pulmonary rehabilitation in the community virtually, and also checking their exercise compliance, so on and so forth, using a system called Florence. In terms of the guide that was sent to the practices early last year, in terms of being able to identify the top 5 to 10 patients within the practices, for instance, type 2 diabetes, where you have a patient of HbA1c over 75 or BMI over 40, is just a guide really, and I'm quite happy to share that again. As far as respiratory patients are concerned, patients who are on a COPD register with an MRC of 3+, or patients who have had 3 or more exacerbations in the last 12 months. And in terms of heart failure patients with heart failure or had an MI in the last 12 months, and patients that require frequent titration in terms of diuretics, beta blockers, or ACE1. So we've also been attending the heart failure meetings with Dr. Ranjan's team at Newham General, for a very long time. So it was kind of like a virtual model in itself, because it's an MDT meeting where we get to discuss patients, and my team sits at the GP MDT meetings on a regular basis. And we recently ramped up the service as well, and we've been working very closely with BARTS, and we've also started supporting patients that are coming out of hospital with supplemental oxygen. So if you have any, I can use this opportunity to also inform that if you have any patients discharged back to your care with supplemental oxygen, please do signpost them our way. We are more than happy to take them on board. So yeah, that's kind of telehealth in a nutshell. And currently we have 471 patients in our caseload. Over to Kate.
Okay, thanks. I think we'll probably leave it at that. You've got the 2 slides that you can look at. We're also working both across Tower Hamlets and Newham with setting up a long COVID assessment hub, working with various departments in the hospital and CCG on that. I think we can take any questions.
Does anybody have any? Everyone's okay with it. We'll just stay until 7:30. So if we got any questions, I'll let you go have your dinners and things. So has anybody got any hands up here? I think Claire's got a hand up, or just is that a new hand, Claire?
Yeah,
and Helen as well. Yeah, Claire, go on.
Yeah, I was just wondering, Kate, I know that you wanted to keep it brief. Could you just tell us very, very quickly what the plans are for the long COVID service?
Okay, so this is an assessment hub, and there is a particular pathway whereby people with middle grade symptoms, if you like, so very mild long COVID, should be able to be self-managed or looked after in primary care. Obviously, more severe long COVID will need to either stay with the acute trust or go back to the acute trust. But there is a middle grade of people, many of whom have MSK pain type symptoms, very similar, in fact, to some of the patients that we already deal with in our MSK collaborative, where we work with you and Barts. These will come into a hub, so there will be a referral form and patients will be assessed, and then there will be a rehabilitation or a treatment pathway through therapy, possibly to the pain clinic, for instance, possibly to our MSK service, possibly to therapy in the community. So this is primarily a single assessment. It's based on a national model, which every system is required to set up, that looks at psychology. Oh, of course, yes, and we will have input from and to our psychology service, so the IAP service, because that's a very important part of this as well. So it's a single assessment for people with that middle grade of long COVID, to assess them and point them in the right direction or refer them on to the appropriate.
That's live at the moment, isn't it, Kate? That's launched from what I could read, what I saw the other day.
It is indeed. Kate's been at the vaccination centre, so I can tell you it is. You should be getting your referral forms onto EMIS as soon as we can. But we've got I think we've got an email address at the moment, but it is going to be.
I saw the email address. Well, that's brilliant. And then the other thing is really just about the what we're concerned about in primary care. And I don't want to take up again too much time. Is about the escalation points. You know, if they're under telehealth. And also about if there's an integrated discharge hub, is that there'll be clear kind of accountability and escalation points, really, and where do those patients go, and that's our questions. But I think again, unless there's like a really 30-second answer to that, we may have to take it to another week.
You mean for long COVID?
No, for like acute COVID. So when there's step down care. The step down care from hospital and they're going into telehealth and going into the integrated discharge hub. It's just like, where would the primary care accountability fit into that as well?
And we do have some agreed escalation processes, particularly for the oxygen step down. With Bart's colleagues that Andrew has set up. Right. Out of hours is more difficult, and there is a reality that some of the patients that we are monitoring we will need to send back into hospital, because in some ways, if you think about it, that's what a monitoring service is for. Some of them will deteriorate and they will need to go back. But we have an agreement to escalate via the ambulatory
So there's no ask of GPs here. Apart from, so there wouldn't be like a major ask of GPs here, but obviously if we do get contacted, we would have clear. Sometimes we are being contacted to be doing some things like oxygen. Like we have been contacted over a few of the patients, but
I think some patients are coming out without having been sent through the integrated discharge hub, and therefore we're not picking them up.
Okay.
And I'm afraid, as things stand at the moment, you need to send them to us, because there's no other way we can get to know them. But if you refer them to us, then we will put them on the service.
Okay, so maybe that's what the issue that's coming up then. Go on, Claire.
Yeah, just to say, there was yesterday there was a London-wide webinar on home monitoring. Today there was a London-wide webinar on COVID virtual wards, which is the monitoring of the patients being discharged. So Kate, you're right. I think some people are coming up. So RAM's feeding the information to us so we can let the acute wards know the ones that are slipping through the net. They should go through IDH. Also, they are putting in place some quite robust systems. So I think we'll have to make things a little bit, as I said, robust. So I think
yes, and I think there will be more data monitoring coming in as well. I think Helen's got her hand up. I don't know.
Helen, yes, I was just going to come to Helen. Helen, sorry about that.
That's absolutely fine. It's a really, really quick point, which is that there is an A&E consultant available from 8 a.m. to 11 p.m. 7 days a week. We are always happy to take a call from you about the best way for patients to negotiate the system. And, you know, if you need to find out when scans are available or want to get someone front loaded for any reason, really, really happy to take your calls. If you just phone switchboard.
Is there a direct number for that, Helen? Because we did used to have a hot zone number, but I haven't rang it recently.
We carry a bleep. So
right.
If you phone switchboard and ask them to bleep the A&E consultants, 8 a.m. to 11 p.m.
bother you too much.
Then you will get hold of one of us. And between 11 p.m. and 8 a.m. there is a registrar who's also really happy to take your calls. There is a direct line number. I'm having some teething issues with persuading my colleagues to carry the phone, but I'm sure that we'll get there. But probably the bleep's more reliable at this stage.
Right, thank you, Helen. That's really reassuring. And actually, Kate, that's really reassuring to know that there'll be very good escalation pathways as well. So I just don't think we've probably seen them yet. Okay, brilliant. Okay, thank you, everyone. It's 7:30, so I think we did quite well in the end. So thank you. I think it's been a really, really helpful webinar.
Sorry, I've just got something to say quickly.
Oh, go on, Amira. Go on. Sorry.
Hi, everyone. My name is Amira, and I'm recovering from COVID. I'm listening to all the services that you've mentioned. I just want to say that I'm not just saying that because it's Newham, but all these services is making such a great impact, because looking at it from a service user, sorry, Kavita, sorry to share this, but
no, this is a really lovely way to end. Yeah.
So 2 days after I got diagnosed, 3 days later, my dad was diagnosed as well, but not from me, because we live far apart. But he deteriorated quite quickly, and I think when he got diagnosed, the first thing, because being part of the home monitoring team, because I worked with them briefly, first thing I did was order the pulse oximeter. And I think from a clinician point of view, you just think the first thing you should do, and I'm glad that I did that, because a week after, just on Friday, I called my parents, and my mum said, he wasn't well. I said, put the pulse oximeter on, and his SATs was actually 86. So from calling 999, it took less than 20 minutes, and the ambulance was there. Between him going to the Royal London, I mean, if I hadn't done that, as we speak, he is in intensive care unit.
Is he, on
CPAP, on dialysis, on everything. And I think we don't, because if we're not using or seeing the impact of the services that we are creating, we don't know how much of a great difference is making. So to 111, to A&E, to all of you guys, I think you're doing such an amazing job. Just that we don't really see it, because we're on the other side. And Dr. Rajesh, thank you so much for your presentation, and I would love to have you at the Nurses Forum.
Oh, thank you, Amira. I think it was so lovely to it's just so moving to actually see the patient stories behind this as well. And I know in our first, especially in the first surge, there's so much silent hypoxia, and we were sending those SATs monitors out, and people had really low SATs. And I know that we've saved many lives just from this. So I would really encourage practices to get the SATs monitors out and use their home monitoring service as well. But actually, but have the confidence to do your own SATs monitoring as well and get them out to patients. Thank you so much, Amira. Thank you, everyone. Thank you. Thanks, Rajesh. Thank you. Thank you for all the speakers today. Thank you. I think we're going to need a second one, but yeah, we'll manage it. Thanks, everyone. Bye.